Good morning, everybody. There is a little bit of static on the line, and we were just trying to see if we could get that to go away, but we can't, so we're going to go ahead. So this is Jolene at AHI, and I'm just going to go around the room here, and then we'll go through who is on the phone today.
Jolene Kalani from AHI.
Rebecca Bigelow, AHI. And who is on the line?
Hi, this is Stephanie Leffler, nurse practitioner.
Ann Becker from Adirondack Internal Medicine and Pediatrics.
Abe from Adirondack Pediatrics.
Jessica from AHI.
Angie Victoria. Sorry. Victoria from AHI.
I heard Angie, Baisha, and Victoria.
Yep. Yes.
Okay.
Mark Adamick, AHI.
Rachel and Summer, Canton Potsdam Hospital.
Kathy Dodd, Canton Potsdam Hospital and AHI.
Hi, Brenda Stiles from the ATO.
Mandy Snay from the Clayton County Health Department.
Megan Murphy, Adirondacks ATO. Cindy Bedard, Medical Home.
Erin Dunn, Hudson Headwaters. Tracy Hart, FDR HCO.
Is there anybody else on the line that hasn't introduced themselves yet? Okay. So today's meeting is going to be about pediatric transitions to adult practices. This is an elective credit, but several of our pediatric practices chose to do this as one of their electives, and it is a measure that the ACO is working on. So we wanted to emphasize what you need for CMH, and then Brenda and Mary are going to go over what the ACO has been working on. And if at any point you guys have questions, just let us know. So for CMH, it's CC20, it's collaboration after transition. And there's a few different ways depending on if you are pediatric, if you're internal medicine, or if you're an adult-only practice. But for the pediatrics going that are doing the care plan for patients transitioning out, or even the ones that are transitioning if you're on the adult side transitioning in when you're accepting the patients, if you want to do this one for an elective, you have to have a written care plan. And it doesn't have to include everything on the list, but it should include some of the bullet points. And the CQA doesn't specify how many, and everybody knows how prescriptive NCQA is. But you can go through the summary of medical information, who are all the providers or who were the providers, what are some of the obstacles to transitioning, is that, do they have a learning disability, do they have lack of transportation, do they have lack of housing, do they have a hard time finding somebody to take them on as a patient, do they have any special care needs, what type of information was given to the patient about what to expect at an adult provider versus a pediatric provider, how do the visits change, how do they go about releasing their medical records from the one office to the other for continuity of care, how did the patient respond to the transition, and what is their actual transition plan. So for internal medicine practices receiving patients from pediatricians, they're expected to request and review the transition plan or to develop a plan if one's not provided for this transition. And for family medicines that don't transition, so if you see everybody from birth to 100, you still need to have a process in place for how do you educate your patients on the changes that happen once you go from being considered a pediatric adolescent patient to being an adult patient, because the visits get a little bit different, HIPAA changes, access. There's a lot of different things that go on. So how are you transitioning internally from those patients from one to the other? And that is the gist of what you have to do to your PCNH. So I'm going to turn this over to Brenda.
All right, thank you, Jolene. Mandy Snay is joining us today from the Clinton County Health Department, and certainly Mandy and her team were really the biggest drivers to help us. I think here in the north, in the northern region, that transitions from the pediatric to the adult practice, or, you know, however we assist patients to make that transition. There's a lot of different things that are in motion, really getting that child, that young adult prepared, what it means to transition into the adult practice, but also the responsibility of the adult practice, you know, moving forward. So I'm just going to let Mandy, you know, go through the slides and talk through this, and certainly if you have any questions, you know, we can discuss further.
Okay. Good morning, everyone. So I'm going to do a nice overview of a partnership that the Adirondacks ACO and the Clinton County Health Department took on in 2019. Our focus was pediatric to adult healthcare transition. The model that we applied, we could probably use for any number of target metrics, but for this pilot, we did actually choose to focus on that transition. So we were looking to strategically use the strengths of both of the health system sectors, clinical and community health partners, to improve quality care and increase healthy behaviors. So we were going to do that by coordinating practice-level QI projects with community-based patient education. So our target performance was that adult well visit for 18 to 44-year-olds. But as Brenda just mentioned, we did focus on the lower end of that adult age range. So our target population really became young adults and their parents and caregivers as we worked through our project. Do I have the ability to forward? Awesome, thank you. So we did allot 6 months total for this project. We started in January and ran through June, even though we went a little bit further into the year than that. We wanted to have both those in-practice components and the community campaign, because we were recognizing that practices can do a lot of work to adjust their systems and have really strong policies, but that patients still play a role in maximizing that impact on health within the healthcare system. So we felt both components were actually very important. We did connect with the practices early in the year. Through January, early February, we were meeting with each of our targeted practices. It was about a 15 to maybe 30-minute get-together. Really, it was a recruitment visit. We wanted to make sure that they wanted to participate with us, but we were also looking for them to identify a practice champion or team lead, and then we had some evaluation components that we wanted them to complete and get back to us before any work actually started within the practices. So once we completed all those initial visits and we were able to get back those baseline assessments, the partners aggregated that data, so we had some baseline measures of what we were looking at and where the practices stood in terms of what that transition looked like within our local practices. By March, we were actually getting back together for one-on-one meetings with all the participating practices. Sometimes we were meeting specifically with the champion that was identified, but in most cases, we were meeting with a small group of stakeholders within the practices that would be responsible for carrying whatever projects were out. We looked at what activities they were going to undertake, what was going to be feasible, what kind of help they were going to need. So we ended up having a loose plan for each of the practices, and really the work that was taken on in each of the practices was a little bit different, even though there was some similarities. From that point on, through the middle of the year, the practices were working on their individual projects, but we did reconvene all of the partners. I actually forget if it was March or April at this point, but we did reconvene the partners once they had started their projects. really to talk about what the different work was that was happening and what was working and what wasn't working. But then there was also a really nice conversation around the overlap between, you know, pediatric providers that are transitioning their young adults out and what that looks like for the adult primary care practices when they're accepting these young adults in. And I definitely think there's a lot more work to be done around that because it gets really complicated in there. But through the middle of the year, practices completed their projects, and then we made sure that they had some of the post-assessment paperwork to fill out, and then we spent a few weeks getting that back from our participating practices. At the same time, we were running a coordinated community education campaign. The messages for that campaign were influenced by input that we collected from the practices, so it didn't necessarily line up exactly January through June. It actually got somewhat of a later start because we wanted input as we were meeting with the practices in that first quarter of the year. We definitely focused on the importance of regular wellness visits, but then also the significance of having a planned and organized sort of transition to adult primary care and what that looks like and what the responsibilities are on the young adult patient, and then also how parents and caregivers can support that. So projects and tools, we were actually really lucky, and one of the reasons we settled on this topic for our pilot project was because the GOT Transition platform already existed. So GOT Transition is actually a platform developed by the National Alliance to Advance Adolescent Health, but is also supported by the American Academy of Pediatrics and the American Academy of Family Physicians and the American College of Physicians, and they had a lot of resources. So we really loved the fact that they had qualitative and quantitative and validated assessments that we could use in the evaluation portion of our project so we could actually measure the progress that was happening. But they also had readiness quizzes and checklists, communication pieces. They actually had toolkits for the different types of practices that might actually be transitioning patients out or in. So they had a pediatric focused toolkit, they had an adult primary care practice toolkit, and then they even had a toolkit for practices that would fall somewhere in the middle, maybe seeing patients throughout the lifespan, but would be changing the kind of care the patient would be receiving, or the patient would be changing providers within the same practice. So gottransition.org, the link right in the middle of the slide will bring you to the main website, and then we have some links there that would bring you to provider resources, family resources, and evaluation tools, all developed by these guys. We were able to use quite a number of resources that they had, and with small tweaks, we were able to tailor them to our local practices. So it actually saved us a lot of work. So practice-based outcomes, we can go right to the next slide. So we started with 11 targeted practices. I think that included all of the ACO participating primary care practices in Clinton County. So we stayed relatively small for this pilot project, and geographically, I think it helped us a little bit to kind of work through and figure out what worked best, seeing everybody was located right here. We did have 10 out of 11 of those targeted practices accept those introductory visits, and 8 out of the 11 practices actually moved on and participated with us, and in the very least completed the pre and post evaluation components of our project. So 100% of the practices that participated with us did decide that they were going to at least look at their transition policy and formalize that and update it. And we were very happy with that. GOT Transition considers having that practice level policy in place related to that patient transition is step number 1 in the guidelines that they spell out. So we liked the fact that everybody was focused on that, but additional activities that the practices identified for themselves were integrating the use of readiness assessments, using transition checklists to make sure everything is done and according to policy. Some of the practices were interested in actually gaining patient experience feedback so they could continue to improve their process, using welcome letters, really looking at the transfer of care summaries. And again, that's one of those things that affects both practices that are transitioning young adults out, and the primary care practices that would be accepting them in, and something that probably more work needs to be done around locally. And then some of the practices were very interested in adding in some patient and parent education materials. So Got Transition had 2 evaluation tools that we took advantage of. One was more of a qualitative self-assessment, and we did have all the practices complete that pre and post intervention, but the scores that we see here are from the more quantitative process measurement tool that Got Transition created and validated, so it was ready to go. The tool itself has 29 different elements that it looks at, and the maximum score is 100. So over to the left here, before we did any work with our practices, the average score on that pre-assessment out of 100 was 12.1. So definitely left us lots of room for improvement. There were lots of things that the offices could identify to work on relatively easily to improve their scores. And based on those items that the practices were interested in taking on for their projects, we estimated that there was an average potential score increase of about 20 points for our practices. So we figured if we saw something around there, we were relatively successful. We can move on to the next slide. There we go. So these are our post-intervention outcomes. As I said, we had 8 out of our 11 targeted practices participate with us. In the end, after the projects were done, we can definitely say that there was a cohort of practices that were very highly engaged, and then there was another cohort of practices that participated with us and reviewed what they had, but maybe weren't as engaged and maybe didn't make as significant of changes within their practices compared to the other cohort, and that's why we've kind of broken the scores out. We were hoping for 100% participation, so losing those 3 practices, it did put us down to about a 70% participation rate, but that's still not too bad. We weren't terribly disappointed with that, especially because of the engagement that we saw with a decent number of practices. So if we looked at all of the 8 that participated with us, there was an average post-assessment score of 34.1, so that was up from that 12.1, I think it was. So that's pretty decent. And if we just look at that smaller cohort of practices that really took on a lot of work, they actually saw an average post-assessment score of 50.5. So they increased their scores on average over 40 points. So we feel pretty comfortable in concluding that, you know, at this point, compared to, say, in January of 2019, the transition processes within our local practices that participated with us are definitely more aligned with those best practices for an ideal transition. So while this was all going on, and we can actually forward right to the next slide, we had our community campaign. We relied heavily on social media for this, and we did develop 14 different social media messages. They were shared 34 times across 3 platforms. CCHD does maintain a Facebook, a Twitter, and an Instagram account, so those are the 3 platforms that we use. The messages were shared over a 4-month period, and they were viewed over 12,000 times. In terms of reach, that is pretty good. This campaign actually did slightly better than I would say our average campaign does that we run. We do also have a blog, and one of our staff nurses wrote a #adulting blog. When we pulled these outcomes, this was back in September, it had been viewed just under 700 times, but we actually looked at it last week, and it's actually up to about 1,500 views. So that continues to be accessed for information. We have since September done a couple of pushes. We have integrated talking about that transition to the adult style of care into some of our just routine messaging. So we were able to highlight that in a newspaper insert that went out in November. It's also been in one of our provider newsletters that went out in September, and we've been able to do some education with school nurses and other healthcare professionals within our school district, and we're thinking that is what, so we drive them back to the blog because the blog has a number of other links in there, so we think that's why those views have actually popped up quite a bit since then. And we were also able to take advantage of a resource that not all communities are going to have access to, but SUNY Plattsburgh does have a very strong communications department here, and they each semester have a class that develops PSAs, and we were able to connect with them and convince them that our project was a good topic for them. So in a very short time, they were actually able to create us a nice series of public service announcements. They were all 30 seconds long, but because they were developed by our target population, we felt like they were really well done and hopefully appropriate, and people would be engaged with them. So they were a little silly, kind of fun, but it cost us nothing, and the college actually distributed them to the 14 regional radio stations at no cost to us. And then we continue to have those files, and we've shared them out with our provider practices. We've used them in some additional communications out to the public, and we'll have them to continue using them into the future. So that worked out really, really well. The next few slides are just some of our examples of our social media posts, so we can just kind of flip through them slowly so people can see them. The picture or visual is what would have shown up on your feed, and then the words over to the right-hand side are what would have been below, and then you can see our hashtags. I think all of those bit.ly links actually do, I think they're all the same, and they link back to that hashtag adulting blog again, because we had so many links within the blog for additional information. I definitely like the folded sheet one the best, but if you don't fold folded sheets, you don't understand. So our objectives, we did set some goals for this pilot project. We weren't really too sure what to expect, but before we headed into doing anything, we kind of teased out some things that we were hoping would happen. So as I mentioned, we did set a lofty goal of having 100% of the practices that we targeted participate with us, and we didn't quite meet that. But again, we had a decent number of practices at least follow through and review what they were doing and really sort of think about how they could improve their process. We were hoping that 80% of the targeted practices would demonstrate progress in meeting the 6 core elements of healthcare transition, and that's how the GOT transition platform actually organizes what the transition should look like. If we consider the 11 practices, we only hit 36.4% there, but if we only look at the 8 practices that we feel participated with us, we had about a rate of a 62.5% in improving their scores. We were hoping our local school districts would be a really great partner in getting our social media messages out. Unfortunately, our community campaign really hit its peak push when the schools were going out on summer break. So that didn't necessarily pan out the way we wanted it to, but we have since then been able to connect with all of our school districts. All of the school nurses have been educated on that transition and the significance of it. They're also aware of this project and what it was working on, so they have that connection. And we are working with each of our school districts to figure out different ways that we can get this messaging to their students. So we feel positive that because we're building this into our routine communications out into the community, that we're going to be able to do something with each of our school districts. And we'll continue working on that into 2020. We were also hoping that our partner organizations within the community would be willing to share out and retweet the messages that we were putting out via social media. We are also working on that because we ran into some obstacles, and I can talk about that in a couple of minutes, but that's also something that we're going to continue working on into 2020. And then we had some longer term or longer range outcomes, and obviously we were looking to influence that compliance with the wellness visit across all payers. So I'm thinking what Brenda has said is that by middle of next year,
Yeah, first quarter, we should have an idea of how decided to looking for our increases across all payers. We'll be doing our data extraction the first part of the year, and so hopefully, you know, we'll see that improvement across the board.
Yeah, and then same for that compliance with the wellness visit. We would love to reach that 90th percentile for all payers, but it'll take a little while until we actually have the data that would show if we met that outcome. So just thoughts for next time. We do feel that this model can be applied to nearly any of the quality goals that we may be working on within the healthcare system. And we think the model worked pretty well, but some things that we may do a little bit differently or kind of adjust or hold on to. So maintaining that collaborative approach and the use of the evaluation components. I think the collaborative approach with the multiple partners going to the practices at the same time and asking them to work on the same work really acknowledges that all partners have limited resources, and mostly I'm referring to time at that point. I think it just sort of acknowledges on the practice level that they can't necessarily be working on a whole bunch of different things and actually get done what they need to within the practice. And I think if we're working together, we can just make a bigger impact on those metrics that we choose to focus on. The use of the evaluation components is just best practice overall, but it does allow us to capture a measure of progress. And I think that can be really reinforcing to the practices as they're changing things so that they can see their hard work paying off and what it's actually doing. And then it also allows us more easily to share our outcomes in situations just like this. Otherwise, we would have been waiting a really long time for that practice level data to kind of catch up. The shorter practice level, so I think we would shorten up our practice level project periods next time, maybe engaging fewer offices at one time. We may maintain that 6 months total for the project. But for the most part, the projects that the offices were working on were relatively easy, and they could have been accomplished in much less time than we allotted. And in fact, keeping the practices engaged for that entire 6 months turned out to be much more challenging than it needed to be, and it was really unnecessary. So maybe staggering the projects, you know, working with a couple of offices that are ready to go from the get-go, and then preparing some other ones to take on that project maybe in a month or two when they may be more ready, will actually be better for all involved. So on the last slide, I was talking a little bit about our community partners and having them share out messages. We're actually working with some key partners to prepare them before we need their support. So the reaction time that we got from community partners to either share out Facebook posts or retweet messages that we had put out wasn't necessarily ideal. They ended up having like a lot of questions and didn't fully understand what we were asking them to do. So we're looking at clarifying that so everybody's on the same page and they realize what we're working towards. And then, of course, having the right contact at each of the organizations so we can really do things relatively quickly and passing that out. And then I don't think we will have any of the problems that we saw in this community campaign. And then we're also looking to define what a community campaign actually is. So it's terminology that I think is getting thrown around more. So for our purposes, we're going to define it so there's consistency in what is done in the future, and then we'll also know the exact metrics that we'll be able to do if that consistency is there. But overall, I think the practices did really, really great. And I definitely think, again, we can claim that there have been improvements in what that transition looks like, even though there is still a whole bunch more that we can work on and will continue to work on. Thank you. Yeah.
Did anybody want to ask any questions about the project, or? So this is really quick. I'm sorry, go ahead.
This is Luann, a couple things. So the links that you provided on the slide, will that get them the assessment tool and all the details they might need to learn about the project itself?
So it's going to bring you to gottransition.org, and we use their tools. So the evaluation assessments that we used, yes, are absolutely on that website. I will say there are evaluation tools made specifically for the type of practice. So when you go to that website, you're going to see like 3 columns, and you can go into the provider site, and there's going to be 3 different toolkits based on the type of practice that is there. So it won't necessarily talk about our project, but it's going to have a lot of the resources that we use.
Okay, and is there contact information for whoever is going to be kind of leading the next round of projects that people could at least contact you to have a discussion?
So Luann, I think at this point, you know, it would be really looking at the different regions and working with the health departments there. I think Mandy is certainly willing to share her expertise and what they went through here. But, you know, our engagement was, you know, we've worked closely with the health department. We saw that this was an opportunity to help our practices not only through the NCQA process, but we also knew that this was an issue. And if we're going to really start making a difference and impacting, you know, the outcomes of these measures, as well as, you know, getting that preventive message out there that, you know, they do have to start taking control of their health and what are their responsibilities, it really, you know, is going to be different, I think, within each region and what the capabilities are. But I think the platform is there, and certainly we'd be willing to talk to, you know, the different regions and how they would, you know, be able to assist with this.
Okay. And then lastly, are you able to share the practices that went through this? So maybe if there is a practice that's thinking about it, they could contact that practice and have a discussion, you know, practice to practice?
Yeah, I think, you know, if they want to, you know, they could contact me and we could, you know, see, because really if they're a family medicine practice, I think, you know, if you're transitioning kids from a pediatric provider within the practice, that looks different than somebody who is strictly, you know, an internal medicine or it's the pediatric side. I think one of the things that I know that we still need to consider, and we still hear this loud and clear, is what does that information look like that is transitioned with the patient to the adult practice? I think there's information there. We heard loud and clear that that was a place that we needed to look and really make it consistent. So certainly I'd be willing to make that contact for the practice and make that connection.
Okay, thank you. Does anyone else have any questions?
So really quickly, the next couple of slides is just, we wanted to hit, you know, flu and pneumo, the flu season is upon us, and really looking at, we're sharing the ACO as far as regionally where we were. So this is just showing in 17 and 18 our performance as far as the influenza vaccination. I think the big thing here is, again, when we're doing chart reviews and thinking about what we're doing within the practices, is really where is this documentation? So number one, it can be accessed, but also I think a lot of us, I think we do a lot of work through NCQA, and I think if the work that we're doing through NCQA, this is one of the places that I know the practices have focused, and you know, there's you know, whether it's email or notes in your portals, just reminding everybody of the vaccination. I did include, you know, the Medicaid performance that there was identified through claims over 9,000 people who received the flu vaccine during the performance year of 17-18. And I think the big thing there is I couldn't really, there's a lot, for the PPS, there are a lot of, the denominator would look like we only had a 10% compliance. We know that's not true. I think how the information is gathered, if people are going to free clinics, and if you know, people who work in the healthcare system and they're getting their immunization done at work, that all remains at work. And if there's no claim put in, we're not getting any information. What I've learned as well is that a lot of the adult immunizations, it's not required for those you know, those vaccines to be loaded into NICIS, you know. So again, it'd be another place for us to think about where are those immunizations going and how do we keep track, you know, being able to identify that. People are getting their, you know, vaccines, you know, at grocery stores now and at the pharmacies, and how do we share that information? If you want to go to the next slide. So this is, again, I was just putting out there what, you know, what we're looking at as far as this measure. It's a HEDIS measure. It is a CMS measure. And as well as, you know, a lot of our payers, you know, certainly look at this, and they are required to keep track. Next slide. So again, one of the things with the flu vaccine that we've noticed, and I know that we've gotten a lot better over the years as far as within the ACO, the flu vaccine, you know, if a patient declines, we've gotten a lot better about making those notations in the charts. If somebody has a medical reason, making sure that that allergy is listed. And if there's a reason, you know, if vaccine is not available, if there's a shortage, if those things are documented, people can receive credit for that, you know, so it's not showing as if you never offered the patient. And we're doing much better of recognizing that. The patient notifications, you know, through portals, when we're thinking about what we can do to encourage our patients to receive the flu vaccines, our mailing. I know a lot of our providers here in the area that are no longer doing the immunization in their office themselves. They have been working with local pharmacies to come in and provide those, you know, vaccine clinics for their patients. And I know that several of our practices are actually having very good turnouts, you know, from their patients being able to show up at the practice to get that immunization. So again, that's increasing their compliance and seeing that within their practice. And again, you know, another side is utilizing NICIS to be able to show that those immunizations were given to our adults. And I think that as we move forward, I know that there's going to be a stronger, it did not make it for CMS this year, but I know it's held off. I think 2021, we will be seeing an adult measure for immunization for CMS. And then lastly, just where we are regionally as far as the pneumococcal vaccine, and certainly for our 65-year-olds, old and older population. Can't talk this morning. You know, we do fairly well, but and I think we capture that documentation, you know, fairly well. And again, what our Medicaid numbers were for 2018. Thanks.
Okay, so, I didn't change part of my slide, and I just caught that. So for questions to go back to the transitions, for pediatric practices that are on the line, what are you guys doing to transition to adult providers? Like, how are you handling that right now? All right, Abe, what are you guys doing?
Well, I mean, we see our patients until their 22nd birthday, so they're mostly so that they can transition through college while not having to worry about trying to find an adult practice. And then at that point, usually at their last well visit, we have that conversation, where do you want to go? And we get mixed results. We try to proactively, the patient says, I'm going to practice X, and we try to send a transition of care document, but some of those practices are like, don't send us anything until we're ready to see the patient. And since the patient doesn't need anything, if they're relatively healthy for like the next year, they kind of just drop off the radar, and it will be several years. But with our more complex patients, we've gone as far as actually, one of our doctors has actually gone to the new doctor's office with the patient for their first visit to review everything, just to make them more comfortable with our complex cases. So it's kind of a little bit in between, everything in between. Some of it is like our college kids, so they're leaving the area when they're done with college, so they're transitioning to a practice, somewhere else in the country or the state. So it's, they're not necessarily on the same page as what we're all trying to do around here. But we still try to have the documents all ready so that when, they find a practice that wants to accept them, we can transfer them over.
Thanks, Abe. And I think you're really the only pediatric-only practice on the line today. So adult practices, what are you guys doing? So when the pediatric practices contact you with and specifically, I guess, for the complex patients, what do you do to accept those patients? If anything, and if not, it's okay to say that you don't really have a process in place.
Good morning, it's Lisa at Dr. Gupta's office. I was a little late connecting to the meeting, I apologize. We have a unique situation where we have a pediatric physician and adult physician within our practice. So in terms of preparing the pediatric patient, the doctor has the conversation, like Abe said, about transitioning to adult medicine. And we do give them the option of transferring over to the other side with our adult provider. The patient's told that their chart is, here, it's in our system. Their care follows them very closely because the two doctors can discuss the care between themselves. If it's a complex patient, one of the good things is that if there is a complex patient, Dr. Mukta Gupta can speak with Dr. Sanjeev Gupta about that patient. So we kind of let them know that their care, is kind of packaged, given to her, but she has that opportunity to speak with him. And we do have, I would say, 90% of our pediatric patients follow with our adult provider. Dr. Gupta, the pediatrician, will keep some of his special needs patients up until the age of 24. Some of those patients are not ready to transfer out of the practice or to transfer over to the adult medicine side. But we try to make that as smooth and easy as possible for those patients, as we have several on the spectrum within our office. So he will bring them over to the other side of the office and introduce him to Mukta and to the staff. And each time that they're at the office, he will, again, let them engage with this side, the other side of the office. We call it sides because we're on two sides. So we try to make it as easy and informative for the patients. We do make them refill out all the paperwork as an adult, discuss insurance with them, and try to make it just as easy as possible. But I think that we have one, that's an advantage for us, that our pediatric care can be followed in the same office. Everything's right here. And I think it just makes it a little easier sometimes for them as well.
Great, thanks, Lisa.
You're welcome.
I just thought of one other thing too. We've worked really hard to get we have our schedule booked open up to a year out. So like a patient that's coming today for preventive care will, before they leave, they will schedule next year's well visit. But one of the other obstacles we run into is that that's not something that's a common practice outside of our practice. So patients that are transitioning out that need like an appointment a year from now, everything may be all fresh in their head and they're reaching out to that doctor's office, but they're like, our schedule's not open that far, so, you know, call us back when it gets closer. You know, so we've built this habit all through teenage years of them coming in every year, booking next year's appointment and coming, and then that ends when they leave us, if that makes sense.
So for your adult practices, typically how far out do you know are your schedules open? Summer? Yeah. Do you know how far out you guys are booking out?
Hi, this is Stephanie. In our practice, we have multiple providers, and we could accommodate a new patient within 10 days.
I think my question's being confused. No, what I'm saying is the patient had a well visit today. They don't need another one. They don't need, right now they're perfectly healthy. They don't need anything else till next year. In our practice, if they're not transitioning out, they can book next year's appointment today. Can I book an appointment for 12 months from now in your practice? Because I don't need anything right at the moment. And my insurance isn't going to pay for a second well visit this year.
Our practice does allow booking out a year or 2 years at a time.
Okay.
Yes, that's consistent across all the Alice Hyde Medical Center practices.
What about, who else is, Camp Potsdam? How far out do you, I mean, I know Abe's down, Abe is down in Glens Falls, but just to get a sense of how far out other schedules are. Or Ann? Anybody? All right.
Jolene?
Yeah.
This is Summer. We're currently onboarding. We just onboarded 3 new primary cares just within like the last month. So that number is changing for us. I've been working with the pediatric providers that we just got onto the New York State PCMH standards. They're very interested in getting something like this going. I think just with our shortage of primary cares, we were struggling for a little while. So it's kind of hard to like say exactly how far out we're booking because that's changing pretty drastically right now. I'd say right now it's just a couple of months. So like we would be able to do a transition like that where we would, like if somebody was hitting their 18th or their 18-year well child, that we would then be able to schedule something onto primary cares from there.
Does anybody have anything else that they'd like to add to what they're doing currently or issues that they have? Okay. So, as a reminder, I know I sent out an email to everybody about the MY5 Depression Screening with Cotivity. So far, well, as of Monday, we still need a minimum of 127 compliant records to meet our goal. And this may go up. I know that they just got about 150 in that they're still processing, but to date, if the percentages stay the same, less than half of those will be compliant. So today, out of the ones that have been submitted, only 85 are compliant, but we have 118 non-compliant. So this is for the depression screening measure. Compliant means that if the patient was seen during the time period, did they have a depression screening? That's the first thing. And then it goes, if the depression screen was negative, then they're compliant. if the depression screen was positive, did they have follow-up, appropriate follow-up within 30 days? The answer is yes, then they were compliant. If they had a visit but no valid depression screen on file, then they are considered non-compliant. And if they had a depression screen and it was positive but there was no follow-up found, then they're considered non-compliant. So this is just so you guys know, we do still need 127. If you haven't, and not everybody got one, so if you haven't been getting emails from me, you can completely disregard this. But if you have been getting emails, just make sure that you've sent them in, and if you're not sure if you have any outstanding, just let me know, and I can check our records to see how many do you have outstanding. We do have a little bit of time left on this one, but we were hoping to get a lot of it done by the end of January, just so we could say one way or the other, did we meet it without it running into the deadline. So for the January work group, the next one, we have been working in conjunction with Medical Home on different work plan tools for PCMH to go forward. So we'd like to get everybody's feedback on the tool that we have, just to see going forward what you'd like. We're also going to do an 80K wellness update. And we're going to be sending out a survey with requests for 2020 meeting topics. So if you have anything any questions or any topics, or even if you have a project that you've done that you want to present to everybody to showcase the work that you guys have been doing, just let us know and we will get it on the schedule. But we would like feedback on what do you want to hear next year, like what do you need information on? And then I'd also like to let everybody know that this will be my last work group. I have resigned my position, so my last day with AHI is January 8th. And I will be sending out emails to everybody to let you know who your point of contact will be going forward. But it has been so wonderful to work with all of you through this whole process, and I'm going to miss every one of you guys. So that's what I have for the work group. Does anybody have any final thoughts, questions? All right. Well, thank you guys, and have a very happy holiday season.
Thank you.
Have a happy holiday.
Thanks, Jolene.